This 72-year-old gentleman presented with myelofibrosis in a way that many patients do. Went to their primary doctor because they weren't feeling well. He had abdominal symptoms. It had fatigue, night sweats, and unexpected weight loss. His primary physician examines him, finds a spleen that is markedly enlarged. Blood studies are done. The patient is found to have anemia, unexpected leukocytosis, and some circulating blasts. A subsequent bone marrow confirms that they have JAK2 V617F mutated myelofibrosis with a chromosomal abnormality in chromosome 20, which would be fairly common. So a classic presentation of primary myelofibrosis. Myelofibrosis can present in a variety of ways. First, as individuals where it is the initial diagnosis as primary myelofibrosis. We were unaware they had a hematologic malignancy. And this case very much fits that picture, where there were several months, sometimes a year and a half, of worsening difficulties. Now, those difficulties come from a variety of areas. One, they may be symptoms related to the spleen. That could be abdominal discomfort, it could be fullness, it could be their pants aren't fitting right or look unusual in some way. That could be the presentation of symptoms, unexpected weight loss, sometimes early satiety. I'm filling up early when I eat. That could be a pronounced fatigue or night sweats. Additionally, patients can present as having evolved into myelofibrosis from previously having had ET or polycythemia vera. Now, that presentation is a little different. Those individuals would have been managed sometimes for a handful of years to many years, frequently 10 years or more, where they would have had diminishment in their blood counts. They would have noted those same sort of symptoms or features in terms of their spleen potentially enlarging. And they would have noted potentially a change in their symptoms. So it's not uncommon that the patient who comes to me who now has post-PVMF is a patient who tells me that 6 months ago, 1 year ago, they really noticed the change with the worsening fatigue, unexpected weight loss, and potentially abdominal symptoms. Evaluating the patient for myelofibrosis, an accurate sense of the spleen is important. Most commonly, that's by physical examination, with the standard measuring the number of centimeters below the left costal margin in the midclavicular line. That location is probably only important just to be consistent in the area in which it is measured. Indeed, measuring it by palpation, given the irregular size of the spleen, can be fraught with some challenges. One, it's important to measure in the same spot. Two, it's important to have a consistent approach to where it is in the patient's breathing cycle, because taking a deep inhalation or expiration certainly will move the spleen. It doesn't matter which approach you take, but it does matter that you are consistent. It is for these reasons that the clinical trials with myelofibrosis have frequently used volumetric assessment by MRI or CT or ultrasound, because evaluation of the spleen by palpation is certainly as much art as it is science. Misdiagnosis of myelofibrosis certainly can occur, with the common confounders being first amongst the other myeloid disorders. So fibrosis can be present in chronic myeloid leukemia, or it can be present in MPN MDS overlap syndromes, or in myelodysplastic syndrome with fibrosis. All of these are chronic myeloid malignancies, but the differences between them are important and may have relevance in terms of treatment, in particular if they have BCR-ABL and are CML with fibrosis. Additionally, it's important to know that although not common, secondary causes of fibrosis continue to remain, including autoimmune diseases, chronic infectious processes, and others. Now with the advent of the MPN-associated driver mutations, the JAK2V617F, the calreticulin mutation, the MPL, these certainly help to provide great clarity. I strongly advise all my colleagues to use the WHO diagnostic criteria to be certain they have the right diagnosis for the patient. The current NCCN guidelines also request that the WHO criteria be utilized in diagnosing these patients.